Hello, my name is Michelle Morand, and I am a precision cancer medicine educator and advocate. And I'm here today with the cancer guy, Alexander Rolland, precision cancer medicine research expert. He's the exceptionally knowledgeable human being when it comes to things about genetic testing and the newer therapies, and most importantly, how to most effectively match patients to the most beneficial therapies. So Alex, you have prepared a presentation for us today. Tell us all about it.
Yeah, so this presentation is all about chemotherapy for premenopausal women with high risk hormone receptor HER2 negative advanced breast cancer.
Okay.
The big question, and I always like to bring this back to this doctor that I worked with for a few years. Um, and he used to say that I saw the sun rise for chemo in the beginning of my career, and now I'm watching the sun set. And I love that because, there was this period of time where chemotherapy was considered, the greatest thing. And this is going to change how we treat cancer. And now we look at it and think, oh, chemotherapy, oh boy, still using that?
Yeah, it is important. I do love that story because that fellow had such a long career. He
Yeah,
really was there at the start because
he
chemotherapy
was.
didn't start being a thing until the 70s. Well,
Yeah,
okay,
yeah,
it was tested and experimented with through the 50s and the 60s, but the field of medical oncology didn't even begin until the 70s, and it was specifically created so people could be experts in the administration of chemotherapy.
exactly.
So we got to give credit where credit is due
Mhm.
that a lot of people died before chemotherapy with cancer because all there was surgery and radiation.
Yeah,
So it certainly had its place. But now there's more, newer, better stuff is really the point here.
many, many things. Yes.
Yeah,
Yeah. So we'll get on with the slideshow then.
sure.
So the current standard of care. So patients with premenopausal ER positive aggressive breast cancers are typically given, a variety of different combinations of chemotherapy. A few of them are docetaxel plus capecitabine, paclitaxel plus gemcitabine, or capecitabine plus vinorelbine. Now, this is typically given to premenopausal patients because data has shown that in postmenopausal patients, chemotherapy is usually not very beneficial. And even the benefit in premenopausal is not that significant. So doctors typically save it for people that have high risk situations. And then usually what happens is they're put on, many years of endocrine therapy. If it's premenopausal, then they'll often go on tamoxifen, which is an estrogen receptor inhibitor, or postmenopausal, they go on endocrine therapy of some sort. So whether it's tamoxifen or whether it's an aromatase inhibitor, that's usually the standard of care. And then if they do progress or become metastatic, they're given a class of drugs called CDK4/6 inhibitors. However, recent trial data has shown that a CDK4/6 inhibitor called ribociclib, which is basically a second generation CDK4/6 inhibitor. Palbociclib was the first one. Ribociclib, I believe, was the second generation one, and abemaciclib is the third generation. And so in this trial, they looked at ribociclib plus endocrine therapy, and it significantly prolonged progression-free survival versus the chemotherapy in these premenopausal women with clinically aggressive hormone receptor positive HER2 negative advanced breast cancer. So going straight into the targeted therapy, provided a much better solution than standard chemotherapy.
And that's something you've been advocating for 14 years is let's get started on the best possible targeted approach ASAP. And I'm really glad that studies are just really helping doctors to understand the importance of that.
Yeah, exactly. Yeah. And so a little side note about CDK4/6 inhibitors. They all have a slightly different profile. So some will work if you have certain mutations, others won't. So you can have inactivating mutations that will prevent a certain CDK4/6 inhibitor from working. Also, sometimes you can experience progression on one CDK4/6 inhibitor and then go on a different one and get a response for a while. But the important thing is to really determine, which CDK4/6 inhibitor is best for you is through tumor DNA sequencing. And that's not part of standard breast cancer care at this time, but it's pretty important because if you have an estrogen receptor mutation or a HER2 mutation or an RB1 mutation or a PIK3CA mutation, or a host of different mutations, then maybe these drugs are not right for that particular situation. So very important, tumor DNA sequencing first. And that wasn't done in this study. This was just done on early stage breast cancer to see if we could replace chemotherapy with the standard targeted therapy.
Mm-hmm.
So, the classic example of that is this link here on Gail's case. That was quite a classic example of the application of precision oncology. But the right drug at the right time for the right patient is so essential.
Mm-hmm. Yeah, it's a good example because the doctor had tried to put this patient on a targeted therapy early on, but the proper testing to identify really what was going on and what they needed wasn't done. So, and that happens often. Doctors really are trying as hard as they can with the tools they have to get patients on these new therapies. But without the proper tumor testing, lots can go wrong. That's for sure. Lots of opportunities can be missed.
This is the right choice trial. In this trial, 68% of patients had visceral metastasis. And what that means is that's an organ metastasis, so liver or lung. Typically, it's going to be lung if it's this type of breast cancer. 19% had rapid disease progression. 14 had non-visceral disease, meaning probably bone-only metastasis or lymph node metastasis. And 48 had visceral crisis, meaning that it was damaging one of the organs that it was in. So the primary, not a good selection of patients for a good outcome. These are patients at high risk, and typically these patients progress fairly fast. So the primary endpoint of the study was the progression-free survival. And so the progression-free survival is a time period where 50% of the patients in the trial experienced disease progression. So it's a median, it's just 50% of the patients. We did a video on statistics and understanding statistics of clinical trials and how to determine which drugs are best at this link here. So it's a good idea to look at that if you're doing any of your own research, understand the statistics. And so the right choice trial, patients received either ribociclib plus endocrine therapy with either letrozole or anastrozole. Those are aromatase inhibitors. And then they also had the goserelin, which is the ovarian suppression, because they are premenopausal. And so they do need ovarian suppression. Or they had a combination of the standard chemotherapy consisting of the various combinations of chemotherapy agents. So there's two groups here, basically. So the objective response rate, which is the number of patients who achieve a complete response plus a partial response, in this particular case was 66.1% in the ribociclib group versus only 61% in the chemotherapy group. Now, having a statistic for response rate is not surprising. Typically, these, we'll see an initial response from the chemo right off the bat, as we do with targeted therapies. But that it's all about how long is that response sustained for? How long does that person remain in remission? And that's what really can differ here. So you don't want to get wrapped up in the overall response rate or any one statistic here. And in this group also, the clinical benefit rate was 81.3% versus 74.5% for chemotherapy. And so the clinical benefit rate is basically a complete response plus a partial response plus stable disease. So the patients that had a complete response plus the patients that had a partial response and the patients that had stable disease. So the clinical benefit rate is like the overall response rate, but the overall response is only the positive responses. It doesn't include stable disease, whereas the clinical benefit does include stable disease. Now, there's a little note here. While there's an improvement over standard chemotherapy, it doesn't look that exciting. What you really need to do is look down the road and look at the statistics to see how the patients are doing a little ways down the road.
We're going to do that, I assume.
We're going to do that, yes. So at a median follow-up of 37 months, the median progression-free survival was 21.8 months, with a variance of between 17.4 and 26.7 months in the ribociclib plus endocrine therapy group versus only 12.8 for the chemo group, with a variance of 10 to 18.4 months.
Mm,
And so that's a significant difference. It's almost a doubling of cancer-free time.
yeah.
And obviously, these targeted therapies have less side effects overall than the chemotherapy agents.
Mm,
More importantly, when you look down the line, at 12 months, the progression-free rate was 68.9 versus 54 for the chemo. And
mm,
at 24 months, it was 46 versus 23. So once you get to the 2-year mark,
mhm,
uh, over twice as many patients are still cancer-free compared to the chemo group. That's
mhm.
very significant. And, that's not something we would normally expect to see. So, many doctors do look at the short-term comparison, like the progression-free survival or the response rates, and
Mhm.
see, well, there's not really much of a difference, but they don't look at the long-term results like this, like, the 2-year mark. And so if you didn't look at the 2-year mark, you wouldn't really see a massive difference here.
Yeah, if you just looked at that overall response rate stat you showed us earlier, there's an
Yeah,
improvement. And of course, if your life is on the line, you're still probably going to want the one that's going to give you a little bit better and fewer side effects.
of course.
But here's where we start to see the real benefit of these drugs is that
Yeah,
over time the benefit is more lasting with these
totally,
newer therapies.
totally.
And Alex said something a moment ago, I just want to clarify for you. He said we wouldn't normally expect to see this at the 2-year mark. I want to be clear. He's talking about for patients who are quite advanced. So targeted therapies have incredible benefits for cancer patients at various stages for sure. But yes, with standard chemotherapy, for patients who are quite advanced, we wouldn't expect to see a lot of benefit at
Mhm.
that 2-year mark. But with these therapies, there's quite a difference.
Yeah, so, I always like to say that precision oncology is the right drug for the right patient at the right time. This is a study that really shows timing. In
Hmm.
other words, a drug that's not normally used until the metastatic stage, when given early on to patients that are high risk right off the bat rather than the chemo, it provides significant benefits. And
Hmm.
so, the timing of this drug is pretty important.
Hmm.
So, would these patients still get a benefit if they did the chemo and then went on the ribociclib? That's the thing is they probably would not get that same level of benefit.
Hmm. Yeah, you have the we'll say the gift, the privilege, the whatever it is of having had now 14 plus years experience of seeing the contrast in terms of when people get started on these things earlier versus later. So I just want to acknowledge that because this what you're saying about would it make much difference? That's coming from your professional experience over all this time of seeing what happens when people with similar molecular features or types of cancer start sooner rather than later, or have chemo first and then go to targeted therapies. It does make a difference. So
Yeah.
the sooner we get started on the targeted therapies, the better as a rule.
Yeah, yeah.
Yeah.
So as expected, there were higher rates of hematological, bone marrow suppression, immune cell suppression, including neutropenia and leukopenia in the
Mhm.
ribociclib plus endocrine therapy group. Now, ribociclib is known to do that.
The
So
lower white blood cells, is that what that?
yeah, it's one of the side effects that both palbociclib and ribociclib have.
Yeah.
Now, these are drugs that target what's called CDK4 and CDK6. These are cell-dependent kinases 4 and 6, and what they are is they're actual checkpoints in the cell cycle. And so, if a cell is growing too fast or if it has certain mutations, these checkpoints will prevent that cell from turning into or producing new cells. It's a way of preventing cancer. So, in this particular type of cancer, the CDK4 and CDK6 is altered, and so these checkpoints are kind of ignored, and the cells go through the cycle without going through these checkpoints. And so, what happens with these drugs is they interfere with this, and they initiate that checkpoint process again. So the problem is that both ribociclib and palbociclib, the first two generations of these drugs, target CDK4 and CDK6. But the makers of abemaciclib, which is third generation drug, realized that it was mostly the suppression of CDK6 that was causing these side effects, such as neutropenia and leukopenia. And so what they did was they designed the drug a little differently. So it targets mostly CDK4 and it has minimal impact on CDK6. And apparently, CDK6 is not that important in this pathway for reducing the cancer, but it's really a pathway involved with these hematological adverse events. So we don't really need to suppress it. And so because of that, abemaciclib doesn't have those same side effects. And that's why I always recommend abemaciclib to patients rather than palbociclib or ribociclib.
That's an excellent explanation too. I had, as part of my advocacy work, about 6 months ago, I had some back and forth with one of the heads of the breast cancer, one of the leading cancer agencies in Ontario. And they were insisting that abemaciclib had harsher side effects. They hadn't, I don't think, ever prescribed it. It was new to them. But one of the main reasons they were telling this patient not to bother with it and to stay on the ribociclib was because the abema had harsher side effects. So this is helpful information for me moving forward so that I can better understand why that isn't so.
Yeah, side effect of abemaciclib is diarrhea, but it only lasts for the first couple months and it's totally controllable. Yeah, so definitely as these drugs progress and new generations come out, they're more effective
Mhm.
and they work on more resistant mechanisms like mutations and so on, and they just work better overall.
Mm.
But I'm not saying ribociclib's not a good drug. It's a good drug if as long as you don't have those hematological adverse events,
Mhm.
you're doing good. But some women do, and that can be a problem. And
Yeah.
so there were higher rates of non-hematological events, including symptoms such as nausea, vomiting, diarrhea, and fatigue in the chemo group. And also with chemo, you get neutropenia or neuropathy,
Mm.
peripheral neuropathy in your hands and feet, and plus you lose your hair. So
Yeah.
there's the link to the study. So the conclusions of this that I think is really important is previous data has shown that chemotherapy is not very effective in postmenopausal women with ER positive breast cancers. And often they just go straight into an aromatase inhibitor or even a CDK4/6 inhibitor, depending on their status. However, this trial is significant and it shows the benefits of targeted drugs such as CDK4/6 inhibitors as a first-line therapy for premenopausal estrogen-positive breast cancers compared to chemotherapy. And so, I see women doing chemotherapy all the time with high-risk features because their oncotype test, which we did a video on too, has told them that chemotherapy will provide a benefit to them. But when you look at trials like this, you say, well, sure, chemotherapy will provide a benefit, but here's a targeted therapy that's usually used in a later line that's going to provide much more benefit. And your Oncotype DX does not tell you that.
No, yeah, it's only checking for chemo, not targeted therapies, and that's where it come back to the tumor DNA
Well,
sequence.
it doesn't compare against it just looks at endocrine therapy in general.
So I guess, well, in summary, there's the kind of the zoom in, which is for those of you who have that diagnosis that Alex was just talking about. If you haven't started your chemo yet, let's see if we can get you switched over to this combination.
Well,
Uh,
before you do that, hang on a second.
mhm,
This is a
okay.
relatively new study, number one, and it's published without editing, which is kind of unique. I don't see that a lot. Now, when they initially put it out, I think there was some typos in authors' names and so on. And also, when you use progression-free survival as a statistic for a clinical trial, it often doesn't get as much weight as when you look at other factors such as overall survival and so on.
A little
So,
bit more time.
we still want to look at this trial and see how it pans out. I suspect it's going to stand the test of time. But, before you make that decision, I think it's really important to look at all of the facts and consider everything and look at the mutations you have before you come up with any sort of decisions on therapy.
Right. Thank you. Good reminder. Don't go jumping just yet. Get the thorough analysis of your tumor,
Mhm.
get thorough tumor testing so that you can know really what's going to serve you best. as in the tale of Gail earlier. And it does, that kind of testing, it gives you the evidence that you need to get your doctor on board with something that's newer or that they're less familiar with. And that's really what matters is it doesn't matter if you find a really great option if you can't get a prescription for it. So we need to make sure that all the data is there and you're making the most educated decision. And then it's a lot easier to get your oncologist on board with something newer.
Yeah.
On that note, Alex and his team provide one-on-one consultations, treatment options review. They'll gather your medical records, have a look at all the possible treatments that can be identified for you with everything that's already known about your case right now, and put that into a written form for you, meet with you on Zoom for an hour and talk you through it all. Really an excellent benefit to your cancer treatment program for sure. So highly recommend those. And I have initiated an online self-advocacy training program, taking all the stuff that I've learned from my experience of taking the information Alex and his team have gathered for patients, and then having to work with the oncologist to get the prescriptions and get the patients on the care. So that's free. You can join. There's lots of educational information there. And I host a live drop-in Zoom a couple times a week for you to just pop in and ask your questions. Together, we can just take the steps that you need to take to get you the best care. And of course, visit our YouTube channel, subscribe, and stay informed. There's new videos every week. If there's a particular topic you'd like to see a video on, drop us a line. Let us know. We're always open to feedback. So I hope you found this beneficial. Thanks, Alex, for preparing this for people.